Thank you, Professor Kwan, and thank you, APU, for giving the opportunity. The next speaker for the session, Professor Dennis Lam, has also sent his apologies. He will not be there, so I'm combining the two talks for him as well as in this thing. His talk is on the collaborative efforts for imaging, and my talk is about advancing what has been said by the speaker so far. So there are no conflicts of interest as far as this talk is concerned, and otherwise also, Uveitis people not have that many conflict of interest as such. Not many people fund them. So the challenge with uveitis and why we are gathered here as imaging specialists for the uveitis is that the assessment of inflammation is the key, and we need to really find out from this talk, are there brand new tools or some dedicated tools which will give us an objective quantification of so-called inflammation, and how do we test and rely on some of these branded tools or branded software algorithms and all. So, but whenever we do any of those advances, we need to go back and look into the books. So go back and look into the history. The history is like sun is the standard for uveitis care pathway, whether in terms of nomenclature, and also it has defined the activity of the uveitis in terms of inactive, worsening, improved, remission, all kind of things have been defined by sun. Also, the inflammation in the eye, which we are trying to monitor, because this is what we want to achieve. It is very important that when you are doing imaging, you need to understand what you want to achieve through the imaging. So you want to assess AC cells or inflammatory cells, you want to assess vitreous haze, or you want to assess AC flare, or any kind of inflammation, whatever is happening from front to the back. But these are the three standard guidelines given by the sun about AC cells, vitreous haze, and AC flare. So this is about the AC cells. This is about the flare, which I think all of you know, and different gradings has been there, and then there has been something and some attempt about the vitreous inflammation. So these are the three things according to the sun, and someone was asking me, based on the OCT, what are the signs of active thing you will be able to define. So I don't have a correct answer to it, whether should I call cystoid macular edema or some of those things. We really do not know what are the signs which will tell us based on the OCT or some of the other tests which will be helping us and increase this pool. But right now, these are the three things which has been given in the literature and with which we follow, besides some other things on FFA and ICG and many things. But the challenge with these things are, these are subjective. So what I see, what my friend ZX sees, what my other colleague Dr. Ho Soling sees, we all see probably different, and sometimes there can be grading. It also depends on, I run a clinic in NCID, I'd see 0 cells or maybe 1+, and I come here and see on a hextrite slit lamp and suddenly those cells become 2+. I said on a Takagi slit lamp it was 1+, and another slit lamp it has become 2+. So it is sometimes depend. I switch off the room light, suddenly there are a lot of cells. You keep the lights on, you can't see anything. And then you feel ashamed in front of your fellow is able to pick up the cells, and you as a consultant is not able to pick up because you think you are overconfident and you just no need to switch off the light. So these are the variations which comes into practice, and we need to acknowledge and appreciate that there are variations there. These are non-continuous. You do not have like 1, 2, 3, 4, 5. You have like 1, 2, 3, 4, some steps, but there has not been that many attempts. And you really, from 2 to 1 is okay. Can I change Bradford 4 to 1s? Or cells of 3+ to 1, do you change? How do you change? Because there is no continuous grading of that, and poorly discriminatory and all. So these are the outcome measures which has been used in the clinic and also in the clinical trial, and result of which is inter-observer agreement, treatment guidelines are not very clear, management decision making, a high failure rate, need for more sensitive inclusion criteria, reliable endpoints. So this gives us the background about the imaging. So imaging comes to our rescue. We have already seen about some of the things, and everyone picks up their own tool, own toy. There are so many toys in the thing. I cannot be saying that I master all this toy. So I decided to pick up my own toy in 2012. So with my very dear colleague Jason Lim, who is gone into oculoplasty, probably he struggled with this choroid. So we wrote a small grant in 2011 when that time EDI OCT was not there. And I thought we should look into the choroidal thickness. And that was my first ever $10,000 grant, which I got, but could not get anything, only 20 patients recruited, never published. But I was still interested, went to Moorfields, understand that the choroid has much more in this, and there was a software developed by Adnan Tufel, Srinivas Sada, and Pierskin. He given me the software to look into the choroidal vasculature and choroidal structure and all, and I started looking into it. For me, whenever I try to do a bit of groundwork again, understanding about where is the choroid been studied, what has been studied, what is missing out in the literature. So I again went back to the blackboard, understanding about what it does. So we wanted to see, can we divide the choroid and come up with the segmentation and all, and this was my first attempt. We got 20, 30 patients, and I thought, let me check what I can see as a qualitative outcome. So whenever we talk about imaging, it is qualitative and quantitative. So this is a qualitative. We graded these images into retinal parameters for inflammation and choroidal parameters, and these are some of those things. After this, I have never used it. This was only to get a paper published into one of the journal. But I still don't do, but I use it sometimes clinic, but subconsciously because I'm practicing, but I just use it not like I have a checklist and I check mark whether it is there or not there, or binary kind of thing is there. So these are some of those qualitative changes which we need to appreciate besides the quantitative we talk about. But always, because we all love numbers, we always keep talking about how much is the macular thickness in terms of microns, meters and all. I thought we should be looking into a number, and that is why I generated this number of called as choroidal vascularity index. Some of you might be familiar. We wanted to analyze and see how much is the vasculature, and this you can see the segmentation through an animal eyes which has underwent a laser CNV, a laser induced CNV, and you can see the segmentation which was done. So we thought it is a simple non-invasive way to monitor choroidal vasculature, was repeatable, quantitative, proven, cheap. You don't have to buy. You just integrate this into the existing OCT machine and you don't have to buy any separate software. Published many papers to prove. We went to Zeiss, hey, we got the tool, can you integrate into your machine? No, you cannot, because you haven't proven it. Thought, this is not proof? No, you haven't proven it, because we have not used the ARI network, ARI network. I said, no, we don't know how to use it. No, you have to prove yourself. So this is what we proved, but we were told that you have not proven, and then we cannot use it in the clinical practice. So I think they might have some merit, but we continue to publish, and these were some of the publications of choroidal vascularity index in patients with uveitis, whether it is a pan-uveitis, serpiginous choroiditis, VKH, again VKH with another group of patients from India, and in India with Chennai and Bangalore. So we looked into multiple papers, and we come to this particular paper which we are writing now is about the meta-analysis about all the publications on CVI in uveitis, and this hopefully should be coming. This was presented at last year ARVO, and hopefully this will give us some bit of understanding, and this paper will be coming up hopefully soon, presenting about some of the things which CVI can tell us in context of the uveitis. But because Zeiss told us that, hey, you cannot go and do that, we thought we set up our own ARI network, which was Advanced Retinal Imaging Network. We had our own network by that time called as COIN. COIN is Comprehensive Ocular Imaging Network. But when you talk about a collaborative platform, you cannot be just having a choroid. We thought we introduce other measures for assessing inflammation. One was vitreous haze, then we introduced retinal vascularity index, and recently we are launching iris vascularity index, which I'm not going to talk about. But you can see on this snapshot the vitreous haze which can be assessed, the retinal vasculature which can be assessed, and iris. So this has not been proven so far as much as choroid has gone, because this has been done in last 2 to 3 years through different grants, and we hope that if we put all this together, we will be able to come up with better quantitative measure, and therefore we call it as a bit more advanced image analysis. So just to get you a glimpse into retinal vascularity, there has been work done. It's not the first time, and none other than Alexander Invernizzi has done wonderful work during the time of retinal vascular diameter and vasculature and uveitis. So we developed our own software. So this software allows you to pick up arteries and veins, segment it into different calibers, and then gives you an insight into what's happening and give you an artery-venous ratio. So we did that in COVID. We did it in multiple patients. We are doing it in the patients of uveitis to see whether it gives you a difference and at the baseline cross-sectional between the uveitis and non-uveitis, and for a follow-up longitudinal, does it give you a difference, a meaningful change, and are you looking into something better, something different, something with our existing tools like fundus images. So we'll not get into that. There are some results, very preliminary. This is just to show you the work in progress, inactive, active uveitis, control uveitis, longitudinally what happens, trying to validate. So for me, anything which we want to propose, we want to validate it before people in the group or the community of general ophthalmologist or uveitis specialist can use it. So that's what something which we are trying to do. So we'll quickly jump to the last part of this talk, which is the vitreous dot index. And this is again a tool in progress. and we are pretty confident this will give us a very strong measure which FDA is looking for, looking into the vitreous haze. So this work done based on the sun, the different images, then there is a Zen and Davis score also, and there have been attempts to do it. But what we did is segmentation of the OCT images, manually picking up the vitreous, then calculating the vitreous cell density or the vitreous haze density. So this is the segmentation of the OCT, then calculating the vitreous cell density, then haze density. And there have been work done by, first was done by P.S. Keen, but mostly this work was done by Tariq from Manchester, and he wrote the software which was further validated by Pierce and Alistair Denniston. And we try to use that software with the images from Centon after getting the approval for one of the studies, sirolimus, but we were not getting very promising results. And then we thought of developing our own software. So my own current software, I think we'll come to that quickly, is this, which allows you to segment the vitreous into the posterior vitreous, mid vitreous, and anterior vitreous. And there is a logic why I divided the vitreous into these hypothetical zones of posterior, mid, and anterior vitreous. And then we were able to quantify the vitreous cell inflammation in any of these three bands of the vitreous, telling us that vitreous cell density can tell us. And we are coming up with the publications. And we, one of the attempts which we want to do under this study is we want to compare with the vitreous hemorrhage as well. Can we differentiate using the OCT vitreous hemorrhage from vitreous inflammation? I don't know, but we are trying to make an attempt and see whether we can do it or not. Once again, these are all work in progress. Please don't go and use it and quote me and that Dr. Rupesh has said this in this thing. But these are all things which we can think as a researcher and all. So what are the applications of this? It can help us define and progress and all. But eventually with the goal which all of us want to achieve is a biomarker to use it in our clinical practice by every single person, not just sending the images to a image reading center and then they tell you, you cannot, your patient cannot wait. You want to take a decision there and there itself. Therefore, this tool need to be integrated into your OCT machine. Whether it is CVI, whether it is vitreous, whether it is retinal, has to be there, accessible to you, and then up to you, how do you want to use. So this is where we want to see this biomarker or advanced imaging analysis to be coming and hitting our clinics and helping us manage our patient. With that, I'd like to thank you for your patient listening, and thank you very much.